get ready to rock and roll. Okay, well, welcome, ladies and gentlemen, to this George Eliot March Board. We're delighted to see all of you, and we're delighted to have our friends from the armed services, in particular, Brigadier Tim Hodgett, regarding the Armed Forces Covenant, which we're just about to sign. But just before we do that, I just want to talk about a colleague that we lost last week. It's with enormous sadness that I'd like or have to record the death of our dear colleague Dawn Downs. Dawn was our Unison convener and staff side chair, as well as being an active operating department practitioner, and as well as her work in the trust. And she was enormously busy in the trust. She was a local councillor, did a huge amount of charitable work across Nuneaton as well as in the hospital, and many other areas, including Nicaragua. Dawn was a long-standing member of the George Eliot family and was active. She was energetic, she was supportive. She really was very cared for and loved. She was an incredibly positive force in the trust. She was very engaged in helping to transform the trust over the last few years, and it was always coming from a position of kindness and consideration towards her colleagues, and always looking to make sure that everyone else was okay. Just on behalf of the whole board, I want to thank Dawn's family for Dawn. I know this is a very painful time for everyone who knew Dawn, but I would just like to put on record our thanks at the George Eliot for all of her hard work over the years. You'll be immensely missed, Dawn, and we hope you're looking down on us, and you can keep an eye on what we're doing to make sure we're following on from the great work you did in the past. So with that heartfelt thanks, it sort of brought to me the experiences of so many NHS staff this year working on the front line and putting themselves in danger. But I can ask everyone please to go on mute because it causes a lot of background noise otherwise. And I think there are some colleagues who still aren't on mute. So can I please just ask you to check you're on mute? Thank you. Just thinking about Dawn and the experience of our NHS frontline colleagues over the last year, the way they've had to put themselves in danger to help look after members of the public. It's very timely and very appropriate for us to thank again our armed forces who do that as part of their day in, day out job, putting their lives on the line, that we as a British public can stay safe. So, Glenn, I'll pass over to you first of all. Glenn.
Thank you, Russell, and thank you to the George Eliot team, firstly, for pulling this together, David and Paula and Natasha particularly. Great honour to have Brigadier Hodgett with us today. Tim, you may be aware, my brother would never speak to me again if I didn't sign this covenant. Brigadier General Burley is very supportive of this covenant, so we will be making sure that we absolutely honour the commitment we're making today. Principally, it's about no member of the armed forces community to face disadvantage, but there's so much more to it. There's the allowing our staff and encouraging our staff to be reservists. There's making sure that employment service to spouses and partners is there, making sure that our employees who volunteer to be leaders in military cadet organisations, making sure that we support the Armed Forces Day, the Reserves Day, the Poppy Appeal and remembrance activities, all of those things that we're absolutely committed to be part of. We are, I think we've been reminded over the last year about how important the armed forces is to the country in the way that you've stepped up and helped us in the NHS particularly. And that's been very much appreciated, both actually deploying some of your local teams into our trust, which has been great to see them alongside us, but also the logistic support to the NHS and some of the assistance we've had to the management of this major incident. It's kind of brought us together as as true public servants, and therefore it's a great honour to be able to sign this covenant. So I'll introduce Brigadier Hodgetts if you want to say a few words at this point.
Yeah, Glenn, thank you. And isn't it a small world coming across relatives? But first of all, just to echo the condolences to Dawn's family and friends and colleagues at the hospital, clearly someone who's very dearly missed. And it's a great privilege to be part of this event where the Trust is committing to the values and standards of the Armed Forces Covenant. And within that, there's a particular recognition that a patient's healthcare should not be disadvantaged simply because they're serving, or they are the family of someone who serves, or indeed they're a veteran. But I think it's much more than that. When you support the employment of service spouses and partners, you help their continuous employment as they follow their partner on posting. And we know many partners will be working in the healthcare sector. And when you support the reserves, you're supporting a critical component of our whole force, whether it's through granting reserve training days or mobilisation for deployment. And your commitment to encouraging reserve recruitment is really highly valued. And finally, when you support volunteer leaders for cadet organisations, you're supporting our future and the future contribution of defence to our own national resilience. So I'd say a real heartfelt thank you to George Eliot Hospital, and the Armed Forces absolutely commends your commitment to the Covenant.
Thank you very much. So in this rather strange world in which we live in at the moment, I think we're going to each sign a document in different parts of the country. So I'm just going to sign the covenant here.
And similarly.
And I'll hold that up to the screen. There we are, signed. And Tim, thank you very much. So the covenant is signed. Back to you, Chairman, and you're muted.
Schoolboy error. Thank you, Glenn. Thank you very much again, everyone who's been involved in making this happen. But as we said at the start, thank you for the enormous service of military personnel, veterans and their families for the sacrifices they make. We've come to understand in the NHS family over the last year some element of what you do in terms of your daily service. So we wish you well, we wish you safety. And in the meantime, when you're offered a jab, please get your jab done as quickly as possible. And before you get a jab, wear a mask, keep a safe distance, and carry on washing your hands and stay at home if at all possible. Thank you very much. You're very welcome to continue to join us for the rest of the board, but we will understand if you've got other pressing priorities. So thank you very much.
Thank you, and I will drop out. Thank you very much.
Okay,
Don't
thank
blame
you.
me.
And thank you, David, for joining us for those few minutes before you go back on holiday. You've been a key leader in all of this, so thank you.
Thank you, Guy, also for joining us.
Yeah, no, Guy, great to see you again. Take care. And thanks, Simon, and thanks, Paula.
Yeah, no, thank you, Mr. Chairman. You're very welcome. Really appreciated that. No, fabulous to be part of it. I was going to say the next thing, of course, is Veterans Covenant Healthcare Alliance. Watch this space.
Okay.
We look forward to it, Guy. You take care. Okay, so have we got any new...
Yeah, you too. Thank you.
Thank you.
Have we got any new declarations of interest from colleagues? Okie dokie. So the last set of minutes of the meeting held on the 2nd of February, was everyone happy with the accuracy of those minutes? Please raise a digital hand if you weren't. And just so board members are aware, I am still having technical difficulties with seeing the chat box. So please use your digital hand if you want to make any points. So in terms of action points arising, we go to page 21 of the board pack. And the first was that the NHSE's IPC report received on the 1st of February be taken to QAC for assurance with updates included in the COVID BAF report. That was done, Daljit, and is ongoing. Thank you. Then a patient story on the voice of parents and families be scheduled for the future. That's for the next board meeting in April, the board workshop. Thank you for organising that, Daljit. Then the clinical director to keep Catherine updated on correspondence in regard to the consultant present at night approach taken at Wye Valley and Swift. I understand that's been completed also. And then the high-level maternity dashboard be scheduled on a monthly basis to the public board. That's on the agenda, so we'll come back to that. Thank you, Daljit. A full business case to address the current gap in maternity workforce to be presented in the future. Daljit, when do you think that will come back to us? Okay, Daljit, if you're talking, I can't hear you.
Which one are we talking about? Sorry, Chair.
It's okay. The business case regarding the maternity workforce.
Oh yes, that's in progress at the moment. So there was a wider discussion about other elements of the workforce that might require funding. So they're doing one whole business case, and it's in progress. We anticipate that will be done by April.
Super. Thank you very much, Daljit. Then the submission of the planning framework to the Trust Board on the 2nd of March. That's been done as well. Thank you. And then, thank you, Jenny. And then the COVID virtual board evaluation report, that's coming to the board hack on the 4th of May. So we look forward to that. And then Gertie to report on staff wellbeing. Gertie, do you just want to quickly update us on where you are with this?
Thank you, Chair. Yes, we're having a conversation at the Foundation Group Strategy Board later this month, and after that we'll be able to then bring updates back to the 3 respective trust boards once we've gone through that conversation later this month, but that is on the agenda and planned for this month.
Fantastic, thank you, Gertie. So we'll be able to brief members of the public in due course. Then the Freedom to Speak Up staff evaluation feedback be included in the future. That's been done and is on the agenda. The update on the STAR board, which is a piece of work that Glenn was involved in, we'll come back to that partly in your report, Glenn, but in the future as well. And then Daljit to keep the board updated on progress with the Safeguarding Children Doctor role.
Yep.
Daljit? I think you may have muted yourself again, Daljit.
I do apologise. Sorry, Chair. I can confirm that the mitigations remain in place. The situation hasn't currently changed. However, the locum consultant who's interested in the safeguarding role is applying for the substantive post. Those interviews are being progressed currently. So all being well, should he be successful, we will have a named person. But also just to assure the board that we've already set up any training and development that he may require, so we can progress this as soon as possible.
Okay, great. And can I just ask colleagues when they come on to speak, if they put the video on as well, it just enables us to share with members of the public our profiles. Thank you. And then the FPC to get an understanding of flow data detailed by ward. That was done, Stephen. That's all undertaken.
Yeah, that's been done.
Thank you. And then new requirement of potential changes to the current FPPT arrangements, that's been deferred until further notice, so we'll come back to that. Are there any matters arising that I've missed? Okay, thank you, team. So we'll move on then to your report, Glenn, including a COVID update. Glenn.
Thank you, Chairman. So I'm just briefly in terms of the position today of COVID in the hospital. We have 34 COVID positive patients, 3 of which in critical care. That's a much improved position to the peak of this wave, which was significantly more than double that. And it's been very encouraging to see those numbers falling over the last few weeks, and indeed across the group we've seen a similar trend. Notwithstanding that, actually over the last week there have been some slight increases in cases in the community in Warwickshire North, and what this helps to demonstrate is the impact of the vaccination programme, which I'll talk about in a moment, because through the approach that we've adopted in the NHS, we've been protecting those vulnerable individuals that are more likely to result in hospital admissions. So it's been really positive to see those admissions falling, even though the community transmissions are higher, and potentially will go up a little bit as we ease out of lockdown. There will be transmission, but the key to this is making sure that those transmissions don't result in severe COVID illness, which is certainly the vaccine evidence that is now emerging is really strong on the vaccines that we're using in the NHS. So that's really positive. No sooner had I written this report down than it gets updated by the Prime Minister a week or so ago. So the incredible success of the vaccine programme has led to it continue to accelerate. So I refer here to the remaining cohort 10 being tackled soon, but actually that's now been split into 10, 11 and 12. And if anyone was listening to Secretary of State Matt Hancock on Friday evening, when he did his latest COVID update, he made specific reference to the Coventry and Warwickshire health and care system and the way that we've been the best performing system in the country in terms of the cohort penetration of those first 4 and moving into the 5th cohort. So really great to see that we're protecting our communities. The other thing that they're emphasising here is there is a concern in that kind of residual 10-15% that we have in some of the cohorts, that those may be heightening the inequalities for some members of the community. So we are looking really carefully at that. I met a couple of weeks ago with our Director of Public Health in Warwickshire, and we talked about how we can get the best level of information and to influence the behaviours of some of our hard to reach communities. So we've started a campaign with our comms teams across the group, but also linking into local authority and CCG comms teams. I've done a video in the last few days, which is encouraging our staff members to be those trusted people in the community that can dispel some of these strange stories that have started to emerge around COVID vaccination. So we will be tackling that and ensuring that we don't introduce new inequalities as we move forward. I then give an update on the national ICS legislation. In the previous board paper, I gave a bit more information about what that entailed. What I refer to here is the closure of the consultation and the identification of the white paper itself, which has received a lot of interest. What was very encouraging is the proposals that were set out in the consultation were very widely supported. So the white paper will reinforce some of those issues, make them stronger. It will be recommending the creation of a statutory body in an integrated care system, and alongside that, that will ensure there is an independent body in each integrated care system that will help to ensure that there's effective collaboration between providers and effective integration, but actually making sure that a lot of that takes place at place level. This morning in our workshop, we started to look at the place-based clinical strategy that has been produced by partners and healthcare partners across the system, which is really quite exciting. I then refer to the Ockenden report. We talked about that in the main board meeting. I just brought it into my report here. There's now obviously a focus with COVID hopefully waning and this being the last wave, that we can start to talk about how we start to recover services in the NHS. Main concern for all of us is that at this point our staff are exhausted. Over a year of pressure, over a year of not being able to decompress in the way that they used to by taking time out and being able to switch off. So we are working to support the health and well-being of our workforce, most importantly, but also trying to influence national policy on how we should recover. And what I refer to in my paper here is a new R word, because we've obviously introduced a few R words in it with restoration, recovery. I introduced respite, which I'm not suggesting the NHS needs to take a holiday, because we're always there 24/7 for our population. But our staff actually do want to go back to looking after the patients that they came into their NHS jobs to look after, whether those are crashingly urgent cases or more routine cases. It's their area of expertise, and importantly, they'll be back to working in their team. So I think we need to be just doing that for a period of time. trying to understand the new capacity of the NHS, and then setting out how we're going to recover and what we're going to recover back to. The constitutional standards that have been there for a number of years now have not been met across the NHS for the last 4 or 5 years, and I think it's time for us to, with a new financial settlement, to set out what we're going to deliver. But as I said at the start, the key to that is our workforce being able to recover their health and well-being, being able to get back to some normality. I then go on to provide some more insight into what's been happening among some of our teams. This morning in workshop, we had a fantastic story from our domestic cleaning teams. They're very much frontline workers, like many of our clinical staff, and they talked about how hard they've been working over the last year. And here, the paper talks about our portering and other members of the clinical support services. And I encourage anyone to read through the detail. I won't go through it all. There's so much that's been going on, so many different roles being adopted, and everyone stepping up to the plate to help. And then finally, some Excel awards, individual names there from December, January and February of people who've stood out. It's quite hard to stand out actually amongst an entire workforce that is standing out, but these individuals have been nominated by colleagues for some of the things that they've done, and it's great to see those names there. That's all I wanted to go through, Chairman.
Thank you very much, Glenn. And just on that last point, for members of the public who may not be aware, our sister hospital over at South Warwickshire Swift is part of a large sort of mini documentary on Channel 4 News tonight, which pulls out just the phenomenal efforts of the team there, which are very similar to the phenomenal efforts of the team at the George Eliot. So members of the public may find that of interest. Any questions or perspectives to Glenn? There's a lot happening. Julie?
Thanks very much, Chair. Thanks, Glenn. I think it was a really good report, and I really like the acknowledgements of everybody that's going above and beyond, and everybody that's going above and beyond. I just really wanted to say support your suggestion about this need for respite and to influence national discussion on that. I think it's very important that the board actually supports you on that. And also, I think communications are never more important at the moment around staff health and well-being and around the ICS and what's happening, because it's still in its early days, but actually dispelling any concerns that people might have about the ICS, I think, is really important at this point.
Yeah, I think just building on that, Julie, clearly we as a board recognise the enormous frustration and anxiety of longer waiting lists that have come as a result of COVID-19 affecting the work that we're able to do. But the fastest way for us to address that in the medium term is by giving our teams a little bit of respite, and that will allow us to be super productive. One of the biggest risks is if we don't wisely allow our teams to take some respite, then we will be causing long-term issues to our ability to get into those waiting lists. Any other questions or perspectives to Glenn? Thank you very much, Glenn. Glenn, I am conscious of the fact you need to leave us a bit later to join another call. So when you do, we will understand. We'll therefore move on to the Quality Governance COVID report. Dowjit, particular things you'd like to pull out?
Yeah, thank you very much, Chair. So I'll pull out the key points for the report and take it as read in terms of detail. And then I'm happy for Stephen, Catherine or Gertie, who've contributed to sections of the report, to make any comments. Really like to start off by really acknowledging and thanking our non-clinical military personnel who've been supporting, have been deployed across the trust and supporting in many areas, and providing essential support. So that's been really helpful, and it was good to see the sign-in earlier on. In addition to that, I just want to acknowledge the significant work that's been done in terms of recruiting volunteers, which is set out in the report, and the magnificent contribution that our volunteers have made through what has been a very challenging time for us. And on another positive already touched on was the COVID vaccinations, and to highlight that George Eliot had delivered over 5,500 vaccinations since 4th of January, contributing to the national success, which across Coventry and Warwickshire. In terms of areas that I just want to pull out that we need to be that we're currently focusing on is that we've noted the reduction in incident reporting, likely to be linked to the current pressures in the organisation, and noting that the number of overdue incidents is rising. There is a work plan in place to address that, and we are working on that. We're identifying a growing theme of around communication and visiting in complaints. This has been a very difficult time for our patients and their loved ones, not being able to be together when patient is in hospital, and it isn't the place that we'd like to be, but to emphasise this is for the safety of others and the wider community, as well as the patients in the hospital. Last week it was brought to my attention that there's a national review of visiting going on, and we're hoping that that guidance will be coming out soon, so hopefully we'll be able to revisit what we can do, but we will continue to operate with safety being in our mind. As you can see though from the report, that there's quite a lot going on in terms of finding alternative ways for loved ones to stay in contact with patients. The report also sets out that the appointment for the palliative care consultant is still out, but just for the board to note that the great work that continues around end-of-life care, and that's evidenced by 98% of patients having achieved their preferred place of death, which is excellent work. And finally, in terms of guardian of safe working, there were 10 exception reports which have all now been settled. Happy for Stephen or Gertie or Catherine to add anything else to that, and then to take any questions.
Thank you, Daljeet. Colleagues, anything you'd like to add? Gertie?
Just a very brief update, because obviously the vaccine is a live and moving feast, that we've now delivered 6,862 vaccines as at last Friday. And I think a particular point that the board will receive assurance and encouragement from is that 89% of our BAME staff at the organisation have now been vaccinated. So that's really, really positive, along with 84% of our staff and bank staff who contribute regularly to the organisation.
Thank you, Gertie. Very helpful. Okay, any questions or perspectives to Daljeet or the team on the Quality Governance COVID report? Really phenomenal success on the vaccine in particular, and those numbers you just gave us, Gertie, are really encouraging. I'd like to put on thanks the board's gratefulness to our primary care colleagues who have really done a phenomenal job across the whole of North Warwickshire, to be at the very forefront of, as Glenn indicated, the vaccination programme on a national basis. We'll therefore move on to the Trust and Foundation Group objectives for the year 21-22. Glenn?
Thank you, Chairman. So we had a look at these in our confidential board last month in a bit more granular detail than we have today. So what we have today is more of a helicopter view of the kind of key objectives that we would, with approval today, start to then communicate across the organisation, but also then to form the basis of objectives for the exec team sat there on this call, but also people who work for them and the teams beneath those. So this is an important kind of steer about where we're trying to take the organisation. Thanks to Jenny for the work she's done on all of this. She wrote the report and sets out at the start there the process that we've gone through to ensure that there's really good staff engagement on the principles here. We call them the Trust and Foundation Group objectives because there's a small number of objectives that we'll work on across the group, because by doing so we'll do those things a little bit better, and those are identified with an asterisk in the list on the second page there. But for example, the health and well-being point that I made earlier is one that we will start off, and we're going to have a conversation at our next Foundation Group Strategy Committee with HR directors present about some of the things that we can do and learn from each other on that. So there's a small number of those. Otherwise, these are very much about focused to deliver our local strategy, also to move forward in the context of some of those national changes, particularly the place-based leadership model that we're moving forward on, developing our credentials as lead provider. So a lot in there, and this would be, if we approve these, then we get moving forward on these objectives.
Yeah, and just building on a couple of your points there, Glenn, if you don't mind, Rebecca Karna's kindly volunteered to be the wellbeing guardian at the non-executive level on the board, which is great. Thank you, Rebecca. But we shouldn't underestimate how challenging that shift into place is going to be for the system. And therefore the objectives will not be easily achieved, but are nonetheless absolutely the right ones. We have discussed these before, colleagues. Any questions or perspectives? So we need to approve them. So colleagues happy to approve, please raise an electronic hand if you're not happy to approve. Duly approved. Thank you, Glenn. So we move on then to the estates update and the ERIC report, which is always amuses me for some unknown reason. Stephen.
Yeah, thanks. So there's just three areas that really, taking the report as read, that I want to talk through. So in terms of the ERIC, which is a return that benchmarks our estate costs against other trusts and providers. There are a couple of points just to pull out from that. So overall, our estates and facilities cost demonstrates a value for money. What I would pull out is our hard FM costs and our clinical infrastructure are lower than our peer group, so that's a positive. The one that we're going to do more work on, and it will link to strategies that we talked about this morning in the board development session, in particular use of clinical utilisation of space and our work from home strategy, agile working, that kind of things. Our estate and property maintenance costs are higher than our peer group. So that's an area that Kirsty and the team are looking at. And we're also having conversations in joint learning with Swift estates teams as well. So we're trying to pull that together so we can share learning there. The other thing that I just want to draw on is some of the projects. So the big one that we've talked a lot about is the 2 theatres that are currently being built on site. And the other one really is around the amount of work that's still going on around COVID management in the hospital, so that the estates team are still having to be quite adept. And you heard from the facilities team this morning, that's an ongoing piece of work and particularly challenging. And then finally, again, from board development, we heard about the estate strategy, and there's a section in there how we're linking that into the STP. So those schemes that we've talked about are detailed in there, particularly the elective care centre, that kind of idea. So happy to take any questions.
Thank you, Steve. Just before I invite questions, just for members of the public, one of the things maybe to realise about our estates is because we don't have a PFI and we don't have a brand new hospital, which obviously comes out fully kitted, and as part of a PFI deal, everything gets replaced on a regular cycle as part of the PFI arrangements. Because we don't have that PFI, we obviously need to consume capital compared to others on our patch, just to keep our estate in a fit for purpose position. And that's always worth remembering for members of the public. Any questions or perspectives to Stephen on the ERIC update? I think we should call it the ERIC update. Okay, thank you very much, Stephen. Keep us briefed. And we'll therefore move on to the Restore, Recover and Reset programme, which, as Glenn indicated earlier, should be the 4 Rs. Hack, do you want to lead on this?
Yes, thank you, Chairman. The first couple of areas I was going to cover, Glenn has already covered, so I'll only touch on those really in terms of the vaccination programme, which has been a big part of the work that we've done under Restore, Recover and Reset, and you've heard about the successes around that. That's been a huge team effort across the organisation, also working with partners. The second area, which Glenn touched on, was around recovery of elective services and where we are with those and restoring services. So as you know, with the current surge, we haven't been able to operate at normal levels, but we've managed to keep cancer services and diagnostics going and outpatients going largely as well. So the work over the last month or so has been around the step-up plan and how do we start restoring our services again and recovering activity at pace whilst being mindful of staff well-being and being mindful of that 4th R that Glenn mentioned. So there's a plan in place to be able to start going again, and some services have started again already. So we've used that time well to actually plan and make sure that we're looking after our staff, but we're also focusing on those patients who've been waiting the longest, and that's how we're going to start going again. And there's some details in the paper around some of the work that we're doing on that side of things. And the other big piece of work has been around business planning and preparing for next year, and how Restore, Recovery and Reset is effectively business as usual going forwards, and it's part of our improvement programme and how we maximise use of our capacity. So a lot of the work has been on demand and capacity modelling, and Glenn again touched on understanding capacity earlier on. We're probably in a very good place. We've done a lot of work on our capacity modelling, and we understand our capacity better than we've ever understood it. So we've got a very good foundation to build on in terms of going into next financial year and making sure that we are maximising that capacity, linking back our priorities for next year to our clinical strategy. And we've had some planning sessions with the directorates, and they're making good progress in developing that side of things, and as part of our improvement programs linked to utilising our capacity and productivity, we've got a theatres improvement programme and an outpatients improvement programme, which are really important part of our recovery and reset going forwards. We're also doing a review of our Restore, Recovery and Reset programme as we come to the end of this financial year, and you'll see from the report that 1/3 of the projects have been handed over to business as usual, and I think it's worth reflecting on the amount of work that actually we managed to get through under some very difficult circumstances. So there's a range of projects that are covering additional capacity that we've put in for already in terms of the additional ward, the theatres that are currently under construction, improving flow of patients through the hospital, avoiding admissions, staff testing, track and trace, the various infection control measures, all the work on PPE, which seems a distant memory now, but it was the hot topic this time last year, agile working, virtual clinics, all the work on staff wellbeing and the support we've had from NHS charities, streamlining and improving some of our governance process around business cases and getting those developments through rapidly, and improving our performance framework through the new finance and performance executives. There's a huge amount of work that we managed to get through in a relatively short space of time. So what we're doing is a look back and review and making sure that we learn the lessons, but also celebrate some of those successes. And as part of that review, we've also been working closely with our place partners and looking at readiness for 21-22 and building on the clinical strategy. And we've supported Warwickshire North Place in terms of doing a review of all the priority focus areas through a programme health check. So one of the things coming out of that is that we need to get better at measuring performance and measuring our improvements and key milestones and deliverables and streamline reporting. So one of the key focuses going forwards as part of our improvement work is going to be demonstrating through numbers real improvements in the way we're delivering our services. So I think a huge amount of work there, and so we'll be bringing back a closeout report for the Restore, Recover and Reset programme in May, and then we'll switch to it being an improvement programme report from June onwards. So I'll leave it there and take any questions.
Thank you very much, Hack. Any questions or perspectives to Hack? Rebecca?
Thanks, Chair. Absolutely commendable the range of work that's been achieved in so many projects within the organisation, and that's a credit to our staff and to our executive leaders as well. Particularly interested, I wondered if you could say anything else, Hack, around the area of wider determinants of health and the work that we're doing on that, because it's so important to us in regards to our work at place. I don't know whether you can add anything further, or Jenny is able to tell us further about that work, please.
I was going to ask for some help from Jenny on that one.
Jenny? Jenny, if you're talking, you're on mute. Okay, well, maybe minute that, Rebecca, if that's okay, and come back to you. Apologies. And Julie?
Thanks very much, Chair. Thanks, Hack. It's, as Rebecca said, really good and commendable. I just wanted just to check the learning from the current surge on those programmes that have been completed or yet to be completed. How are we feeding in that further learning for even further improvement? I'm thinking for things around things like discharge or infection control. How are we actually going back in either or completing to reflect that learning?
So as part of each piece of work in each project, there is that review in terms of what is the learning, and sometimes you get other projects coming out of those projects. So there's a continuous cycle of improvement that we go through, and that's using the QSER approach for improvement that we have across the organisation. So it isn't just about doing a project and then forgetting about it. It is that continuous improvement cycle.
Thank you, Hack. Glenn, is there something you wanted to add to that?
Yeah, I put my hand up just before Hack said what I was going to say, which actually is the QSER training, but actually we've moved that to a virtual training arrangement now. So our aim is for lots of our clinical staff and operational staff to be trained in improvement skills, and we have the improvement board that meets, and as Hack says, very much a culture of continuous improvement rather than necessarily separate projects stopping and starting. And there's great evidence of that right across the organisation.
Yeah, no, our work on QSER is fantastic. And I think what would be good, but just building on Julie's point, is whilst we're generally always aiming to improve, a piece of work that comes out of this on what our key priorities are, I think would be good, Hack, and what our key risks are. So if I can leave that as we sort of wind down on this. Well, my second thought is I think we've done a remarkable job at keeping things going, but I do worry greatly about our cancer performance. And Stephen, I think it would be good if certainly next month you could do a real up-to-date bit of a deep dive on cancer, because the numbers certainly in this part of the pack only go up to the end of December. But I'd like more visibility, because obviously cancer is a time critical, it's almost always a time critical issue, whereas some elective work is less time critical. So a bit more profile on what we're doing to make sure the cancer performance is okay. Hack, thank you very much. We'll move on and then on to the report on safe nursing and midwifery staffing. Darjit.
Thank you, Chair. So the report, I'll take the report as read. This report is highlighting our staffing levels in January, and at last board in February, board will be aware that I had highlighted some of the challenges we were having, which continued throughout early January. This seems to have improved in February, but we're still to analyse that data, and I'll bring that back to the next board meeting. What I'd like to assure the board is that there were no harm events which occurred directly associated with the staffing challenges in some of the areas that we had, and due to our oversight and governance of staffing, which has remained tight, we have mitigated any risks and continue to do that. Point that I really want to put out of this report is, which you'll notice, there's a growing number of vacancies in our registered nursing workforce, which has been due to both staff leaving, which we're doing a look into what some of those reasons are, and also opening of additional capacity and beds. As a result of this, we've reviewed specifically our registered nursing workforce risk assessment and updated that rating to reflect the current circumstance. In terms of recruitment, that continues on a monthly basis. We're recruiting to healthcare assistants workforce and the registered nursing workforce, and a number of new staff are due to start in March and April, so we'll continue to update those figures and keep an eye on that. I think what I would like to say, and what we're starting to see, and some of that was reflected in the board workshop around the clinical strategy, we're starting to see some real ambition in the directorates to review their workforce models, and that's based on some of the learning from COVID, where they've tried different roles and staff have been doing different things. So that's really positive. And also, I think it's really acknowledged that coming out of COVID, and this is not just George Eliot, I think this is a national issue, that retention is going to be a really key theme. And this is sort of displayed in the conversations that we've had a part of the planning processes with the directorates, who really understand the implications around that and what the actions they need to be taken over the coming months. Happy to take any questions.
No, thank you, Doja. Really important last point. I do worry that it goes back to Glenn's point on respite, how physically and emotionally exhausted a number of our teams, frontline teams are, and we need to look after them. Otherwise, understandably, they might leave us. So questions on perspectives to Doja. Glynis?
Thank you, Chair. Firstly, just to say, I do take a lot of assurance about the governance around this and the oversight that we have on the workforce and the mitigations in place around the risks, Daljit. But thinking forward in terms of increasing our capacity and the challenge with vacancies and recruiting to nursing posts, and your last comment about retention, I'm just wondering how confident we are that once we've got the capacity, we'll be able to open it up safely. Because that's a critical part of being able to utilise these additional beds that we've got. So what plans there were in place for that?
Yeah, absolutely. So the key thing is obviously looking at both retention and recruitment together. So the bit about retention is that if, you know, it's trying to encourage staff not to move outside of the organisation, but there's opportunities across George Eliot. And actually, the new areas that we're opening up are really exciting, and we're not struggling to recruit into those areas. Surgery have done really well with their recruitment. The other thing we've started to look at is in the report where you can see that the vacancy levels are slightly higher. We're doing some focused bespoke recruitment events and really, you know, highlighting that this is a great place to work, and there are some great opportunities here, and getting the staff on the wards to be part of that recruitment process, so that those people that are applying for jobs can actually see and speak to the people that they're going to be working with.
Great, Doja. Stephen, is there anything you wanted to add to that?
Yeah, I think our evidence is where there's new builds. So Captain Tom Moore was, to be honest, fairly easy to recruit to. So I think the theatre, I wouldn't underplay the role that the new theatres will have with that. And Paula, who you'd seen earlier, is saying they've had some recruitment days and they've got a lot of interest, particularly from university as well. So there's a lot of new people coming out that are interested. The other bit, though, I think, which we can't forget, is you've heard the clinical strategy, and there's a lot of work that medicine are doing around their bed base and reforming that, and that has a big impact as well. So that particularly some of the shorter stay and the ambulatory care offer really attracts people into it, because that's good emergency medicine, and a lot of them like to do that. So it's not just the building that attracts people, it's what we're doing. So I think the evidence is if we can keep going with that, we'll have an offer, and we've got a strategy that's got ambition, and I think people respond to that.
No, that's helpful, Stephen. And Neil, did you want to add to that, or was yours another point?
Mine was a separate point, Chair.
Okay, can we come back to you in a second, because I think it's Rebecca next, please.
Thanks, Chair. Just very quickly to add, similar to Glynis, I take a lot of assurance in regards to the reports that we've considered at QAC in relation to the oversight of this issue in regards to workforce challenges, and also to urge us, as we've already discussed, to consider our offer in relation to nursing and allied health profession vacancies. Whilst we might be a DGH, we've got an awful lot to offer, and we shouldn't accept that people move on in order to advance their careers. Thank you.
Absolutely, Rebecca. The George Eliot is a wonderful organisation to work in. There are many benefits, and you're absolutely right. We shouldn't in any way feel the little sister or little brother. And finally, Anil.
Thanks. So firstly, Daljit, thank you to you and your leadership for managing the risk. My question really was, sometime back, we had a very successful international recruitment.
Yes.
I know that there are national efforts going on around that. Do you want to just give us a quick update on what's happening on that front?
Yeah, absolutely. So, and Gertie might be able to add a little bit more to this, that we did apply for the international resource for nursing available nationally, and in partnership with SWIFT. That is being progressed alongside our usual recruitment. We haven't got any figures or anything to share at this stage, but we will be a part of that international recruitment process. Don't know, Gertie, if you've got anything you want to add.
Yeah, well, we as I've said, we were successful in terms of the national bid, and we did receive some funding on that. And we've planned to have 2 cohorts of international nurses joining us over the coming months, starting later in the year. We pushed it back because of the impact of the second wave of COVID, but taking that cohorting approach so that we can make sure that colleagues have a really good experience when they come to us, and that they then can share and learn together. There's some really positive conversations with the ward staff and the ward managers about taking these staff through. What I'd also say and add to that is apprenticeships is an opportunity for us to grow our own staff, and we have looked at the development of the nurse degree apprenticeship and the nurse associate, and that really is starting to get inroads, and we are looking at planning that further on as well. But I think apprenticeships across the board in all roles, I mean, we've seen a massive increase in this year in our approach to apprenticeship, following on from the paper and the support that went through Trust Management Board about ensuring we consider apprenticeships first. It gives us an opportunity to embed and learn in the community and give back to the community that we serve as well. So I think there are some real positives coming through, and I would hope that we continue to see those green shoots come to fruition.
And
Absolutely.
I can
Thank you very much.
just add that there's really good evidence in the organisation of the nurse associate roles being embedded into the workforce, and we can see those numbers growing. But also this year in particular, what we've seen is the directorates really developing the ACP role, so our advanced clinical practitioners, which when we talk about in particular retention, and that you can stay at George Eliot and still advance your career, is so very important. So Gertie and I will be working on a ACP workforce strategy across the organisation, so that we're supporting and developing those roles.
Great. And I'm sure you know, down at Wye Valley, I think they've had some great experience with the apprentice and the ACP role. Thank you, Daljit. Thank you, Gertie. Colleagues, happy to move on to the integrated performance report. Stephen, I think you're introducing this today. Thank you.
Yeah, thanks. I'll pull out some key headlines, and then if there's questions, and we can direct that through executive colleagues. There's 3 themes really that sit behind the report and that flow through it as a constant. So I just kind of want to bring them to board's attention and bring them to life really, and also for members of the public that may be watching. I think the first important thing that we've touched on, but to go back to when this report was drawn, was the real pressure that we had in the hospital around the COVID numbers, and in particular our ITU capacity. So we had a high number of very sick patients, and it wasn't just in the hospital, it was nationally and regionally we were responding to. So people will be aware that there was a lot of attempts to decompress ITUs all over the country, in particularly starting with the South East and South London, and in our way we played a part in that through the chains of UHCW and UHB. So there's been a fairly significant period of pressure in the organisation around, one, the numbers that we were dealing with, the acuity of the patients and where they were sitting, so in terms of ITU. And in Glenn's report you can see how other people had to be moved and adopted to that. So that's an important thing to note. The other one I wanted to pull out is there's a big section on IPC, and you'll see it in a number of areas where really we're really cognizant, and if there's one priority we've got, it's that IPC priority, to keep the place safe and to make sure that we're not doing any more harm, and that we're managing our staff and our patient safety at the best. So IPC will run through, and there'll be a couple of examples where I'll touch on that. And then finally, and I think it's really important to note, is we're really cognizant of the staff support. So we're doing an awful lot, and it's mentioned in the report around, we've got a lot of psychology input to key areas. So Elizabeth, which is our respiratory ward, and their team are accessing that. We've done a lot with ITU. One of the ones we've done recently is around our theatre staff. So as they've gone back to getting ready to gear everything up for theatres coming back online, we've given them kind of some special time and some facilitated time to almost do a look back on what they've been through. What does that feel like? And also, what's the challenge ahead? And we're going to do that in all our services, because even if you've not been directly affected by COVID in terms of looking after patients, you're still worried about those patients that you haven't seen that are yours, and we've got to help people kind of work that through. So there are three key themes that I think you'll see run through the report. If I do the usual, I'll pull out the headlines for kind of urgent care RTT, and I'll move on to some of the areas. One of the successes we've had is our urgent care performance, really, and although we're not hitting the 95% standard, what we are seeing is that we are benchmarking really well. And one of the really good things that we've seen in this month is some of the correspondence that's gone between us and WMAS in particular. So they've been really thankful to us, and publicly in a recent health overview and scrutiny committee thanked us. And I know that's been replicated in the groups. I think that's really important, because that's a partner, and that is also patient safety, because if they can't be released to go and see patients, those are patients who are waiting for ambulances, and that could be real harm out there. So we take that very seriously, and the department are kind of really passionate about that. In terms of cancer performance that you said, and I think we can put some context to that. So there's three areas that I'd really pull through. One of them is we are maintaining low backlog numbers. So we have been doing cancer operations through this. We really prioritise that, and particularly the time sensitive cancer operations that we needed to do, that we can do here. So in terms of our backlog of patients of waiting, we're holding that position. That's the improvement that we put in, we're holding that, and our 104 days again is staying a lot lower than we were previously. So we put a lot of effort and focus on that. But there's two areas really where I would suggest there's a risk. So one is around breast 2-week waits, and this is for people who are non-symptomatic. So in particular, when you look at our performance, there's kind of three things that are driving it, and we're not alone in this in the region. There's a lot of this happening around. So one is we've seen a 14% increase month on month. That's above and beyond the campaign. So usually when there's a campaign around something, we do see an uptick. This is above that. So we're going to start some working really closely with the Cancer Alliance and primary care to understand what's happening out there, and to better serve that patient group, to see if we can intervene earlier, or if they could be seen. There are alternatives there to do. The other one we're seeing is there's some movement from other areas. So particularly the Birmingham patch, we're starting to see more referrals coming through that way, which is adding further onto that 14%. And the other one that we're all grappling with, and this is where I mentioned IPC, is the reduced capacity, because we're socially distanced and we can't see as many patients as we used to in the clinics. So there's a capacity gap there. We've been working really closely with the Cancer Alliance, and we think we're about to pilot a new pathway for this. And so hopefully that will mean that the clinical triage is a lot more robust. The one thing that I've said through QAC, and I'll say it here at Public Board, is we won't just change a pathway because it hits a performance target and misses the point. This is about clinical care for patients. So that's the approach that we're taking through this, and hopefully we'll start to see that improve. But just to assure Board, we won't be putting steps in that just mean we can hit a target. It will be clinically driven, and the teams are taking that forward. So I think that's a really important thing to note with us. But we will do that deep in-depth dive that you requested. I guess moving on to that is RTT, and that's one area that we're really looking at how we step that up. And in particular, we're trying to take a bit more of a sophisticated approach to it than may be suggested nationally. So the key ones are the time critical surgeries that we have to do. The one thing that comes through this and our RTT is a lot of our pathways are reliant on other providers, and that's why I draw special attention to the pressure that's been in the system around ITU and other elective. So this in no way is blaming anybody else. This is just recognising that pressure has really been felt. So particularly ITU and elective capacity at UHCW, where we have a more reliance on. They have seen significant numbers and been managing that, and there's big numbers there that they've got to get through. So part of this is that we work really closely as a system around their elective recovery is as important as ours to translate that into the performance. So the key thing, so we're stepping that back up. We're really mindful of the restoration and recovery that the staff need. So we're building a plan that's sensitive to that as well. But that's started, so that will be starting in earnest from next week. We've made sure that we're on with the cancers and the urgents, and we're just ramping that up now. And we've been doing some in-sourcing work. not because our staff can't do it, but because they need the break. So that's why we've been using that will work with particularly gynecology. Diagnostics is showing a better performance, and I'm really pleased to report that our MRI is back to normal working in terms of its performance. It's booking at 4 weeks. It was there. That is a really important milestone for them. So they've got rid of their backlog and we're now working there. So we should see improvements working through our diagnostic pathway. In terms of some of the quality ones, one I wanted to bring through was the single sex accommodation. So we're really, we've had really good performance in that on the trust. There are 7 breaches that we're reporting. This is directly linked to the IPC advice that I talked to, and some of the difficult things that we and our staff are having to make is some of those judgments. We'll always do what's the safest and what we can do to mitigate it. And then with these instances, it was managing an IPC risk, and that was the greater risk, and will put patients at more harm. So that's why those are there. There's investigations going on with them, but we know headline that's what was driving that. There's quite a section on mortality, so I won't go through the details of that, but just to pull out, there's quite a robust process with that. And again, we're open and transparent about what we do around there and the duty of candour with that, so you can see the detail in there. And then finally, just touching on, even despite all of this, there's a lot of recruitment activity, and I think the domestics mentioned that this morning, which was good to hear. But there's some really key medical appointments that we've made, so cardiology, anaesthetics and rheumatology. And although they've not quite translated yet, there is an awful lot of recruitment activity around paediatrics, and that's shown some really good signs that we'll keep board updated on. But we're getting a lot of interest in that, and the interview process that Daljit mentioned earlier is growing. So we will see some people come through that, particularly on our consultant rota. Quick canter through, happy to take any questions.
That was very comprehensive, Stephen. Thank you. Questions or perspectives, Glenn?
Some great work, as you say, Stephen. There's a lot going on, despite the COVID activity. There's a lot of real improvement and recruitment, improvement in the diagnostic performance in the 104-day cancer. All of that's good to see. I think the one that we will need a bit more granularity on as we move forward is the elective waiting time issue that you describe. I think we need to start to separate out the time critical ones from the non, and a feature, as you know, of our recovery as an NHS in this is going to be mutual aid. So we understand that UHW have more time critical concerns on their waiting list, and we are seeing if there's anything we can do to help with that. It may be that the capacity we have available is not suitable for some of that activity, but we are going to be managing this as a system rather than as individual organisations, and that's another dimension that we will need to look as we recover, just how much activity we're doing that isn't coming off our waiting list but is helping the system recovery.
No, thank you, Glenn. And Rebecca?
Thanks, Chair. Regarding the people section of the report, I know that there's quite a high vacancy rate for healthcare scientists. It's quite a significant variance, and I wondered why that was and what we're planning to do about it.
Gertie?
Yeah, thank you, Becky. This is one that we've had a brief discussion at Quack about. There's a very small staff group with healthcare scientists. So obviously the lower vacancy rate, which is around about 9 whole-time equivalents, does seem disproportionately high when you convert it to a percentage. Those are posts that we've been working on and struggled to recruit into for quite some time. We are looking at how we can recruit into them and what those areas are at the moment, but there is mitigation in place for those areas. As I've said, they are vacancies we have carried for a number of months now. But what I would say, particularly in terms of looking at that high percentage, is it's disproportionately disaffected by the fact that there's such a small number of staff. Stephen's probably going to add in on the mitigations.
Thank you.
Stephen?
Yeah, I think so. What you've seen, what I would say from the clinical strategy is there is a lot of workforce planning that's now going on in the directorates. So I think what we're going to see with them, and certainly their level of engagement and understanding is developing massively, what I'm seeing in the workforce planning. So I think where we've got smaller groups, we are at risk of that 1 or 2 leaving, and then we're vulnerable. I think what we'll start to see is much more of a succession plan, and what will we do to mitigate so we don't end up reacting constantly. That's what we're trying to ask the directorates.
Thanks, that's really useful.
Okay, any other questions from colleagues? Stephen, just a couple of observations from me. The first is on, if you like, the long waits comment that Glenn made. Given the way we do ophthalmology, I'd be quite interested to understand the level of weights and the flex on ophthalmology. Perhaps you could brief me privately on that. It's just that it's one of those sort of service lines that might seem less clinically important, but if you're old and you need a cataract operation, it's very destabilizing. So I'd just like a bit of a briefing on that, if you'd be so kind. My second observation is that you said we're not in the blame game, talking about other bits of the system. And I think that's important. We're definitely not in the blame game. But what we are in the business of is it's important to hold to account the system, or those parts of the system which are having a significant negative impact on the well-being of our patients or citizens. And I think that's always a balance. It's not about being throwing stones from the greenhouse, but it is very important for us to hold the parts of the system that have responsibility to do certain things, that they do them well and they do them in a timely manner. And on that point, Glenn, I think it would be worthwhile us reaching out to our pathology network colleagues to say that we do want to have a board meeting. It's been a long while, and because of COVID, we haven't been able to do that. But again, on behalf of our patients and citizens, I think we need to start to put out the pathology network under a degree more pressure going forwards as we approach the new financial year. So if I can ask you to do that, that would be great. Glenn, sorry, you've raised your hand.
I've made that call already, and I have a call with the pathology network director this evening.
That's great, Glenn. It's great the way a process of osmosis works between us, and you know what I'm thinking without me actually having to verbalise it. That's always a good sign. Okay, so moving on then to Hack, the finance report, please.
Thank you, Chairman. So we've seen an improving financial position over the last couple of months, when they're forecasting a break-even position for the end of the financial year. And it's worth remembering that we started off with a planned deficit of 2.1 million. The improvements have been partly driven by additional income. So we've received £1.2 million additional from the STP reserve in recognition of the underfunding of our initial block allocation. We've also seen our position improve as a result of the impact of COVID, where we haven't been able to do the planned level of elective activity, and also some of the fill rates for bank and agency shifts have been lower than we originally expected, due to either staff being off sick or having to self-isolate. There's a small risk in relation to non-tariff drugs, but we're managing that. I'm not expecting that to impact our forecast break-even position. On cash, we will see a reduction in our cash position for next month. It's to the tune of about £13 million, but we will still have £29 million worth of cash. The reason we will see a reduction is that the advance payments of the monthly income will stop, and they'll go back into the normal cycle of payments from April onwards. And on capital, I've previously flagged a risk around COVID capital. We have now received just under £700,000 of COVID capital funding. The remaining 1.7 million I'm expecting to be funded through the underspend that we've got as an STP. We're just working through finalising that position across the STP, but again, that risk is now, I'm not expecting that to be a risk anymore, basically. So quick canter through the key financial highlights there, and I'll take any questions.
Thank you very much, Hag. So just for the avoidance of doubt, at the moment we're being paid a month in advance.
Yes.
And in the future we're going to be paid in the right month.
Yes.
At the end of March, therefore, you're expecting us to still have 29 million in the bank.
Yes. Down
from around 40 million at the moment.
Yes.
Thank you. Any questions or perspectives to Hag? Hag, one of the things that we've talked about, but is I think going to be very important going forward is us, as we come out of the COVID situation, giving ourselves assurance that in terms of our core efficiency and productivity, that we haven't slipped backwards as we come out of COVID. The COVID time is obviously special. The cost metrics all over the place because of the way we've been having to work. I'd just like you to, in particular with your finance colleagues in the ICS, STP, to take back to them the need to try and have some benchmarks going across the three providers on the acute side in the STP, to be able to do some comparisons on an apples for apples basis. As we know, people can always argue that they're special, but I think it's important for us as a board and all the boards in the STP to get assurance that in terms of core efficiency and value for money, we either are doing the best we can for taxpayers, or we're certainly identifying the areas of focus for us to do better. Can I leave that with you, please? And can you maybe give us an update at the next board?
Yes.
I do know, for example, that at Hereford and Worcester, the STP over there, the finance forum, which is chaired by a non-executive, is doing an awful lot of work in that area. So I just want to make sure that same level of focus is being given in Coventry and Warwickshire to learn from one another. Colleagues, happy to move on? So hopefully we have Sue Pike with us, and indeed we do. Sue.
Hello.
And for the Freedom to Speak Up Quarter 3 report. Sue, over to you.
Thank you. You'll be pleased to know I'm not going to read it all out because it was rather long this time, wasn't it? And going forward, it will be abridged and shortened and more of an oversight. And this level of detail will go to TMB. So colleagues, you can breathe a sigh of relief. So a few things to pick up because I'll take it as read. A little bit of a comparison from this time last year. So our quarter 3 figures for 2019-20, we only had 6 cases. So you can see that we've actually moved on quite a lot because there's 17 from quarter 3 this time. Throughout last year, through 2020, we were pretty consistent each quarter with around 15 to 20 cases each one. So steady increase over the year, and it's been great to see that level continuing despite COVID. Picking up on the themes and trends, as always, they're pretty static from quarter to quarter. A slight jump this time in systems and processes. That's more around things like the red-green areas, things where staff aren't quite sure about a process or a policy that's being followed, and that's the sort of thing that gets categorised in that bracket. And as usual, things like attitudes, behaviours, personal relationships with colleagues tends to be fairly static. A quick note on the length of time for cases. There are a few, as you can see, from quarter 2 and quarter 3 that have gone over that 12-week period. It's not high numbers. Generally with those, it's because staff are not in the workplace, or they've been redeployed, or there's an extensive investigation or some HR activity going on around the case. So assurance that they are being moved on. Sometimes it just takes a long time. A couple of them that are over 6 months, I have in the past kept those cases open until I'm assured that the individual is actually happy with an outcome. We've realised with experience and with time that actually some staff won't ever be happy with the outcome that they have. So I just keep in touch with them from a pastoral care point of view and make sure they're okay and that they've got the support they need. And even if they're not happy with the outcome, we will still close down the case now, as long as patient safety or staff safety issues have been addressed and that any actions needed have been put in place. So hopefully going forward, our length of time for cases will reduce. As was on the actions arising, I was asked at last board to provide a little bit of information about feedback we have. So we've at George Eliot had more of a verbal feedback mechanism or an email touch base, but during this quarter we introduced the it's a Google form at the moment, so that goes out to all staff that speak up through me. They get an email with a link on. We only had 3 replies to that during this quarter, but really reassuringly all 3 of them were pretty happy with the service they'd had, not necessarily with the outcome. And all 3 of them did say they would speak up again. And that's the key component for us, because the National Guardian's Office asked us to reflect on how many staff that have spoken up would do so again if they needed to. So that's really positive. Going forward, hopefully we can have more data, and you can see from the comments that we get that most people are happy with the service. So to pick up a bit more about the key learning outcomes, some of these you will see are a little bit detailed. Some of them come from more wider learning from across the Guardian's network and from other campaigns. So the one around bullying, harassment, incivility, some of the narrative from that actually is from wider campaigns. It's not necessarily specific to George Eliot. The thing to say that is specific to us is obviously we've got real plans to roll out civility. We'd started some excellent work around our behaviours, working with Gertie and the HR team and the OD teams, and all of that has kind of stalled a little bit because of COVID pressures, but we're hoping over the next 12 months that that'll all be revitalised, and our ambassadors, myself, HR teams and other colleagues will be instrumental in bringing that training and that level of behaviours up, hopefully, which will only improve our speak up experience. The one that says about staff not necessarily feeling safe to speak up, you've got to take that in context that some of the staff I speak to, it's only 17 people, so it's not everybody in the trust is scared of their manager. So let's just put that on the table. But a lot of staff's experiences, they're a little bit tentative about speaking to a senior leader or a manager, or if it's a lower banded staff, to their supervisor. They're a little bit twitchy. They don't always think that they'll be perceived very well or that they'll be seen as a problem for raising a concern. I think going forward, the e-learning for health package that's now out there for leaders and managers, which is the level 2 freedom to speak up training, if we encourage all of our managers to start doing that training, hopefully that perception will change and managers will be able to react to people speaking up in a more positive way. And then the one around the cases and how we look at them afterwards. So I've agreed with Gertie this week that myself and the head of HR will meet on a monthly basis now to go through all the closed cases, and that will give us more of an oversight of what's happened, the themes, the trends, what actions have been identified and how we're going to disseminate that learning through our directorates. So that will be coming, and that will be really good and a good way to give you assurance as a board going forward. And then I think the last thing of note is our ambassadors over the last 12 months have dropped off a little bit, mainly due to pressures. And we do want to recruit more ambassadors and maybe have a rethink and a refresh about how they are appointed, who they are, the level of responsibility that being an ambassador has, and whether we've got that right. So that's also a piece of work going forward, and hopefully we will have another Freedom Speak Up advisor to support my role in the trust going forward as well. So happy to take any questions.
Thank you very much, Sue. Thank you for your hard work. Glenn, is there something you want to add just before I go to Gertie?
Yeah, I mean, great work as ever, Sue. I mean, by the time we next meet as a board, we will have seen the National Staff Survey, and there'll be an opportunity for us to triangulate some of those issues with what's coming out of that, and we'll obviously spend a bit of time looking at that at board as well. And you always hide your light under a bushel, but I think you haven't mentioned that you're about to take on the role of the regional chair for Freedom to Speak Up for the whole of the Midlands region, which is I'm not surprised, of course, but to your great credit.
Oh, you're my role model because you take on all these national things as well, so I thought I'd follow suit.
Keeping the pace going before it becomes too much of a loving. Gertie?
Apologies, Russell, but there's going to be a little bit more loving of Sue just for a moment. What I would say is I think you can really see the last 12 months and the period of time since Sue's been in post, the massive improvements in the inroads we've made on freedom to speak up. I'm really hopeful that when we have the staff survey and it's unembargoed, we will actually see an improvement in people's willingness to speak up. I think I would just note that Sue's mentioned in passing the additional freedom to speak up, and thank you to Anil and to HAC, because we've had charitable funding support for that through NHS Charities, and I think that will really be helpful in terms of reaching those hard to reach areas like our BAME and our staff who have other considerations, as well as our night workers, and then really focusing on the role of guardians, not just to be freedom to speak up guardians, but we've talked an awful lot through board workshop this morning and also today at board about well-being, as that these would be combined guardians so that they can work through and support that, and we will update board on that further. But I think there is, a real need to note Sue's excellent work and to continue with that. So thank you, Chair.
Thank you. And Rebecca, who's our Freedom to Speak Up non-executive director.
Thanks, Russell. Sorry, I am going to continue this, Lovin, because it's really interesting looking at the national data for organisations of similar size to ours and seeing how we benchmarking in regards to the reporting of freedom to speak up and how that has certainly improved considerably over the last year. So thank you so much for your hard work. We've spoken about the plans to increase our network of ambassadors, which is really positive. Though I just wanted to ask you for assurance that if I were permitted to come on site and come into the hospital, what signs as a member of staff might I see that freedom to speak up and its agenda is still very much a priority for us at the moment? What evidence might I see? Where might I find it?
Lovely. You always ask me a tricky question, Becca. So obviously our intranet, we do try and refresh the information on there around freedom to speak up as regularly as we can. All of our staff networks now are in place, and I'm an active member of all of those. So staff that were actively engaging in those would see me. Obviously, I'm not on site as much as I were, but I try and engage through Facebook, through Instagram, Twitter, all of the socials, and actually we get people speaking up through those routes as well, which always surprises me, but that's brilliant. On the ground, obviously we're not doing as much as we were in 2019 in terms of road shows or leaflet dropping, because we've just not been able to, but going forward that will be the plan. And in terms of freedom to speak up ambassadors, I'd love to get to a position where we have an ambassador for each ward area, each department, each team, from a really diverse background of people, including our night workers and our BAME staff and our other underrepresented groups at the moment. So going forward, even more so, hopefully.
Thank you, Sue. We can't rehearse that communication enough. Thank you. Thanks, Chair.
And I think just sort of finally, you talked about our civility, and civility saves lives. We had a great presentation this morning from our frontline cleaning team. We call them domestics, which sounds a bit upstairs, downstairs to me, but we were talking about the absolutely key role they play. And Tilly, who was one of them, who's got an absolutely fantastic attitude, was calling out some poor behaviour from colleagues, and so was her colleague Kelly, about people who weren't being civil. So I think there's a really important agenda about civility and kindness, and being considerate of other people, particularly when we're all under such, or the frontline teams are under such emotional and physical exhaustion at the moment. So Sue, thank you very much. You're not getting any more praise from me. Just get on with it. But you're an absolute star. Oh, you've gone. I did. Thank you very much.
Still here, just hiding my blushes now.
Okay, thank you very much for your hard work. As Gertie has indicated, we wouldn't have made the progress we have done without you. So take care and stay safe. We'll move on now then to the maternity clinical negligence scheme report. Dougie, what would you like to pull out on this?
Thank you, Chair. Just to say that members of the Directorate might join us if they're able to, just in case they come, but I will happy to talk to the report. Essentially, the report highlights our current position in relation to our CNFT compliance for Q3. In the last, I don't know if the board will recall, but the last time we updated the board, we made the board aware that there was new guidance that had come out and a review has been undertaken. So that guidance and the focus on COVID within the Directorate has had an impact on our progress around this, and we're currently compliant with 4 of the standards, and I believe we may have be now compliant with another one, making 5. I just need to check the evidence on that one. In terms of the ones where we're partially compliant, there are actions in place which are described in the report so that we can aim to be compliant by the revised submission date now nationally, which is July 2021. The one non-compliant area is one that we weren't able to meet last time as well, and that's around multidisciplinary training, which obviously due to COVID and social distancing has had an impact. However, we have put some mitigations in place. We have started some e-learning packages, and also where we're able to, in a socially distance appropriate way, have reintroduced some multidisciplinary face-to-face emergency skills training as well. I'm happy to take any questions on this.
That's great, Darja. Incredibly important area of work, this. Questions and perspectives to Darja. Julie?
Thanks, Daljit. I'm just a bit intrigued by the overlap between this report and the next report.
Yes.
And just wanting to be clear how they overlap, how they interrelate, and what that means in terms for staff in terms of reporting, activity, duplication. So I just want to understand that, because there might be completely separate requirements, but I'm just not clear in my own mind.
Yeah. So I think you're right, Julie. You know, as we had the meeting last week, there was myself, yourself, Julie, and Glynis and Simone to talk about how we can integrate this reporting better, because there does seem to be a lot of reports around this. So the CNST are a separate set of standards, and we know that Ockenden recommendations are fairly new. So while they're linked, you know, it's a bit difficult to actually give a report on both of them together, because the CNT standards are so specific that we're required to meet them. But obviously they underpin some of the work of the result of Ockenden around, for example, you know, leadership elements there, the stuff around data. But it is difficult to try and you know, bring the 2 reports together. I think with CNST, because it's so very, very specific, it's important to bring that assurance separately.
No, understood, and we have to do that, Daljit. But just as a matter of interest, how many hours of time would you estimate, or do you want to have a think? We'll come back. How many hours of time would it take for the production of those 2 reports? Oh,
you know, I mean, I think for the CNST report, there's a bit about the data collection. I think right in the report itself, you know, for the if you put the number of versions that they probably go through, it's probably half a day, and that's just the Directorate team. And then obviously the assurance is checked by my deputy and myself as well, so that adds to that. The self-assessment would have taken quite a bit of time. It's a shame nobody from the Directorate's on here, but you know, I get a draft version, but the checking of the evidence and going back can go backwards and forwards over a number of weeks to make sure that we've got the data right.
Yeah. Can you thank all of the team involved in the production of it? Because I know it's important to produce this stuff, but actually the most important thing is to be getting it right in the first place. And you know, it's that balance of what our senior leaders are doing, whether it's checking, you know, the reduction of a report compared to checking the improvement in the service. So can you please thank them?
Of course, yes.
Colleagues, happy to move on? And thank you, Daljit, for staying with you on the Ockenden self-assessment report.
Yeah, that's right. Thank you, Chair. So in February board, we brought a paper, and it was great that both Gary and Claire from the Directorate could be at the meeting to go through it themselves. So I'd hoped they'd be here today. And that report was quite high level. It was the initial request from NHSEI on the Ockenden recommendations, where we described our compliance and the progress that had been made. And I think it's important to distinguish the two. What we have here is a more detailed self-assessment, which was subsequently produced and required to be submitted on the 15th of February. So you can see that this is quite a thorough report. We did decide to bring the whole paper to the board because we felt it was important that you could see again how thorough it is and the amount of work that's actually gone into ensuring that we give, we provide that assurance and a very open and honest reflection of where we are with things. This was reviewed in detail at Trust Management Board before we submitted it in February, and went to QAC in February as well, but it was after it was submitted. Again, a very detailed conversation was had and provided by the Associate Director of Midwifery. So the report highlights a number of areas where we are partially compliant, and you can see from that these are related to where we are expecting some national guidance, which is still awaited, or where there is some action required from the LMNS. To resolve that. Until we have that, we're unable to progress and assess whether we're fully compliant with those areas. And there are also a couple of amber areas in there which are in progress. So there's one about the birth rate plus, which the board received the birth rate plus, and we talked about earlier on, as an action that's going into a business case. And also we're reviewing the leadership structure within midwifery. Happy to take any questions.
No, that's great, Dalgit, and an incredibly important area given the horrific experiences of patients and their families in South and elsewhere. Any questions or perspectives to Dalgit? We have talked about this before. Glynis?
Thank you, Chair. I just wanted to reiterate the point about QAC. One of the things we're doing is an increased focus in light of the early findings from Ockenden. But we, as Dalgit said, we're looking at how we can be proportionate in our reporting, but still strengthen our insurance. And that's a piece of work that we're doing as a subcommittee. So just to reinforce that this has had a lot of scrutiny.
Thank you, Glynis, and thank you for your chairing of QAC. And any other questions? Okay, super. So we'll move on then just to the continuation of board business, during the pandemic. This is for noting. Sarah, anything you'd particularly like to add?
Nothing to add. I'm presenting it on behalf of David, and he has asked for the board to approve the proposed approach.
Okay. Any questions or perspectives from colleagues? I think, Glynis, that's a legacy hand you have up. Any questions or perspectives from colleagues? I can ask everyone to go on to mute. Is everyone happy to approve? Please raise a digital hand if you're not happy to approve. Okay, duly approved. Thank you, Sarah.
Thank you.
And we've got the updated Infection Prevention Control Board Assurance Framework. Dalgit, particular things you'd like to pull out here?
Yeah. Thank you, Chair. I won't tell you how many hours it took me to do this one, but quite a long time. So to remind the board that last year you received a BAF of the IPC BAF, which was a May version. This is an October version. Just recently, a February version has been published as well, so I'll be looking at that. And what I'll do is just bring any of the different indicators to board rather than the whole BAF again. First of all, want to assure the board that having looked at the May version of the BAF, we implemented all of the partially outstanding actions, bar one, which was around mask fit training, which is a national issue that remains an area of partial compliance in this BAF as well. The October BAF has really grown. There are now 97 key lines of inquiry within that, and we are partially compliant with 9 of those, and fully compliant with all other 88. Again, we had quite an in-depth discussion about this at the Quality Assurance Committee, particularly around 5, which were associated with how the trust captures data, which is at a directorate level, and the BAF is implying that this should be kept at a corporate level. And we provided that assurance to QAC, and it was understood the implications would then mean that we may not be able to be fully compliant with those bits. But I think it's important to emphasise to the board that this is guidance, and there are likely to be areas where the standards need to be applied locally, as long as the outcomes are achieved and those mitigations are in place. I'm happy to take any questions.
Thank you, Darjit. Any questions or perspectives to colleagues? Thank you for your leadership and all of this, Darjit. You know, this is hard graft work, and you do a great job. So thank you on behalf of the board.
Thank you.
We'll move on then to the subcommittee chairs updates. The first of which is the QAC, the 25th of Jan and the 22nd of February. Glynis, is there anything you'd like to add?
No, if I just give you a very quick highlight from our meeting from last week, just to point out that we're still on a reduced reporting schedule, which provides oversight on a reduced number of key metrics, but we do cover safety, effectiveness and patient experience. As a consequence of the pressure on teams, as Daljit's mentioned, there is a delay in reviewing all of the incidents, particularly those as STICE reportable, but we're monitoring those and we're confident that there are plans being taken to address that. I think the other thing just to draw your attention to is we also considered the non-elective laparotomy audit, which highlighted that we're an outlier on this occasion. The review showed that there were some issues with data quality issues, and that's no doubt impacted on our outlier status. And a small number of improvements that have been identified, particularly looking at ensuring that we're making decisions to operate on patients appropriately, as there was some need to introduce some multidisciplinary team reviews to make sure that patients have got a positive prognosis if they go to surgery. And just worth mentioning for members of the public that there are a number of papers that are on today's agenda that will have gone through QAC that are much more detailed papers and will have had considerable scrutiny. So just to note that it may appear that there's not a lot of discussion on some of them, but that discussion has taken place in the subcommittee.
No, absolutely. And the subcommittees for members of the public do a phenomenal amount of work. So thank you for the chairs of that. Any questions to Glynis on either the minutes of the 25th of January or the verbal update on the 22nd of February? Thank you, Glynis, very clear. Any other business from board colleagues? Please raise a digital hand if you have any other business. And any questions from members of the public? If you'd care to come off mute, if you have any questions. David Carr.
Thank you, Chair. I think I'm off mute.
You
Can
are?
you hear? Yeah. In this morning's Coventry Live, there was a piece about the availability of testing kits for COVID patients. I think it was, yes, Glenn, I think it was particularly the PCR version. Can you assure the public that people attending the George Eliot are being looked after in a safe and efficient manner with regards to PCR testing?
Yeah, thank you, David. Interesting that Coventry Live decided to run that story today. That was from last month's board report that was written 5 weeks ago. They obviously haven't got around to reading this month's board report. At that point, there was an issue with rapid testing access nationally. These are the tests that need to be carried out within a 2-hour window for patients being admitted to hospital. There was a supply chain problem, some of which was probably linked a little bit to the Brexit arrangements as well as the pandemic. So there were some mitigations put in place, including nationally approval to use the lateral flow devices as a stopgap, but needing then to have PCR tests to back them up. Just to reassure you, there have been moments when turnaround times have been slower than we'd like them to be, but obviously we have acted in the best interest of safety for patients. So we do not put patients into the wrong parts of the hospital. We make sure that we have a clear test result before we move patients into COVID positive, negative areas, and obviously always maintain infection prevention guidelines in all of those settings. So yeah, it's moved on. It's in a much better place than it was when I reported on that 5 weeks ago.
Thank you, Glenn.
Thank you, Chair.
And I think John Young had a question regarding an update on the League of Friends T-Bar. Stephen, do you want to handle that, please?
Yeah, so the scheme had been tendered and awarded, and really the delay is down to COVID. So there's a couple of issues. One, it's taken a bit longer than we would have liked to agree the schemes and everything, because you're having to do it over Teams, and that's always a bit tricky. But the main thing is access to site at the minute with social distancing and everything that we're doing there. But I think once that moves and we're in a different position than with that, we can progress really quickly with that as a programme of work.
Okay, great. Thank you, Stephen. John, I see your hand's gone up. Has that answered your question?
Yes, thank you, Chair. I just wondered what the current situation was. Obviously, in this lockdown, it's all restricted. But as soon as lockdown, I believe the T-bar's been upgraded. That will be obviously sometime later this year.
Yeah, no, absolutely. Thank you, John.
We can't wait for the tea there either, can we, Russell?
No, cup of tea, new sandwich, salt and vinegar chips, crisps, happy days. Thank you, John. Thank you. Look forward to seeing members of the public at the next board. So in the meantime, take care. If you do get an invitation to have a vaccine undertaken, please take up the opportunity, and please be a vaccine advocate with friends, families and loved ones. Even once you've had your vaccine, please though continue to socially distance, wear a mask, wash your hands a lot, and generally take care of yourself and those you care for. Thank you very much.
Thank you, Chair.
Board, it's 20 to 4. We'll have a 10-minute break